Okay.
Hi guys, we will be starting the session within 5 minutes. Ask everybody to log in today. This will be a very high yield biostatistics class. So, it's just we're nearing the end of the marathon. Ask everybody to join in and then we'll be starting the session. All right, guys, we are now starting this session. Again, it will be a recorded session. If you guys, are not able to understand anything, you guys can, talk to me about it. If you think that I am going a little fast, then, you guys have the authority to stop me, and then I'll, try to revisit the concept again. Okay? Is that clear, everybody? And
Yes.
yeah, okay. Because I heard from Dr. Ahmed that there were a couple of students and they were like, she goes a little too fast. And then I was like, I always ask my students to stop me and, ask me relevant questions. If they are, if they're struggling with something, they should always ask me questions, stop me and say that, hey, Dr. Maheen, we did not understand the concept. All right. Because we're here for you and we want you to learn. All right. So I expect that from you. Okay, so today will be a biostatistics class. All right, I am sharing my screen. Is my screen visible to everybody?
Yes.
Yes, okay.
Yes.
So we will
Yes.
first be starting with the basics, the case control, case series, cross-sectional, and cohort. I want you guys to be familiar with four of the things. First is a case control, all right. The other is a cross-sectional study. The number third is a cohort study. And the fourth is a case series. All right. These four are very high yield in terms of USMLE step one. All right. What do you mean by case control? Come on, guys. What do you mean by case control?
That's the study between the cases. We take the diseased persons and the control persons, which are not having the disease.
Mm-hmm. So again, a very important thing that you guys can look into, that there is A and there is O, right? So case control CACO, two different things, right? So AO, which means you're referring to two different things, right? Now, if you see a cohort, there are two O's in there, O, right? OO are similar. All right. And that is why there is relative risk. I will tell you what relative risk is in the future. But right now, for the purposes of information, just say that if it's cohort, it has two O's in that, and O are related to both one another. And that is why they're both relatives to each other. And there is this thing that we call relative risk, that we used to measure this in a cohort. All right. And case control, they A and O are different. And that is why they are odd, and we use something called odds ratio to measure case control. All right, is it clear, guys? Is
Yes.
it clear? All right. So again, very high yield thing, odds ratio, relative risk. These two are very important in terms of in relation with case control and cohort. All right. Now, what do you mean by case control is that it's basically comparing a group of people with disease to a group without the disease. All right. So A is different and O is different. So that means that there is disease in a patient with disease and without. All right. One has the disease and one does not have the disease. So if you're comparing two groups of people, one has the disease and one does not have the disease, automatically that study will become a case control. Okay. Which will be measured by an odds ratio. Okay. In cohort, what happens? Can anybody tell me what does cohort do?
To the same group of people and comparing the risk in them.
Yeah, very good. Anybody else?
Exposure and without exposure. The
Very good.
comparison of study between exposure and non-exposure.
Yeah. So in this, we see two groups of people and we see exposure or risk factor. All right. So there is exposure or risk factor involved in two groups of people, and one develops the disease throughout and the other does not develop the disease. Okay. So what's basically happening is that the exposure and risk factor are used to assess whether the disease is occurring or it is not occurring. All right. That type of study is known as a cohort. Okay. In case control, we had two different groups. One had the disease and one did not have the disease. All right. In cohort, what's happening is that we are using exposure or risk factor in a particular group, and we are monitoring that group over a period of time to see that if the disease is developing in those people or not. Okay. For example, there is, industrial exposure. You all are living near the industries, near the factories, and there is significant smoke exposure to you. Now, if you monitor, if you, for example, if there is a smoke exposure, all right, and you monitor it through a period of, let's just say, 5 years from now. Okay, smoke exposure, you monitor it over a period of 5 years. You see that some people developed COPD, some did not develop COPD. So, what type of disease will this be?
Prospective study.
Cohort study.
Cohort.
Cohort
Cohort.
study.
Exactly, a
Yes.
cohort study. Very good, a cohort study. Now, what if we did not see the smoke exposure? We only saw two groups of people, one with COPD, one without COPD. Then what it would have been?
It would be a
It's
retrospective cohort.
No.
And
So I
case control.
eliminated the exposure.
case control.
Then case control.
Case
Very
control.
good. Then it's case control. Okay. So if there is exposure, if there is risk factor involved in any of the thing, that means they're talking about a cohort study. If there is no exposure or risk factor, then if they're talking about a case control. Now, cohort studies are divided into two things. All right. One is prospective cohort and the other is retrospective. So you have prospective, all right, and the other is retrospective. Now, what we discussed earlier, like over here, you can see that the smoke exposure developing over a period of 5 years to see if the patients have COPD or not. This is a prospective study. All right. What does this mean? That in future we are going to see if they develop the disease or not, right? But if we go in the back, then that's retrospective. All right. For example, if we would have directly started with these people, with positive COPD and negative COPD, and we are going at the back and seeing that how many, years that, that exposure had occurred to them so that they developed the disease, and that would have been a retrospective disease. All right. So this is, in the future. Prospective means future and retrospective means past. Okay, is it clear, guys?
Yeah.
Yes.
Okay, then, so now we are familiar with the case control. We know about the cohort study. We know in the case control that we are usually seeing that the group of people with disease, without disease, we know that there is A present, O present. They both are different, and that measures that something odd in that, and that is why we use something called as the odds ratio. Whereas in the cohort, there is two O's, which means that they're referring that they're both related to each other. And that is why the relative risk. All right. There's something we use a relative risk to measure cohort. Now, cohorts are again, dependent upon again the exposure and risk factor. And if we look at the disease within the terms of future, then that means they're referring to as a prospective cohort study. If they are referring it in terms of the past, then that means they're referring to the retrospective cohort study. Okay. Now, what do you mean by cross-sectional study? What is cross-sectional?
Looking at a group at a particular point of period in time.
Very good. Anybody else?
Used for checking the prevalence of a disease because it tells that this study involves the that like we see the studies at a particular point of time in a whole time frame, so it will give us the prevalence.
Prevalence meaning
Exactly.
the outcome. Mm.
Very good. So usually in the cross-sectional study, we ask what is happening. All right. There is this question that we ask, and that is what is happening. All right. Why do we ask this question? To check for the disease prevalence. All right. What do you mean by prevalence? What is prevalence?
Meaning all are involved, all group of the patients
Or
are in, people are
how
involved.
often
Yeah.
a disease occurs.
Very good. Exactly. How often or how frequent the disease is occurring. Okay, so what they're referring to is the frequency of the disease, and the other thing is that how prevalent it is and what is basically happening. So, on USMLE step one, they can ask you, cross-section study in terms of these three references. They can ask you what is happening and what does it indicate. You have to click on disease prevalence, or what does it actually mean by, you have to say that it is the frequency of the disease. We are monitoring how frequent the disease is. All right, and that's a cross-sectional study. Okay, now what do you mean by a case series? What's a case series? Come
Like
on, guys. What's
The
one
individuals which have the
specific,
same diagnosis, treatment, or outcome.
and I think you just take one specific disease and you
very
look
good?
at that.
I
This
will
is
make it very easy. For example, there are 100 people with TB. All right. Now, those 100 people are different, right? On one patient, you will write one case. All right. On 100 patients, you will have 100 cases. So, 100 cases on a same disease is known as a case series. All right. Okay, so if you have multiple patients with the same disease, with the same treatment, with the same outcome, then that multiple cases add on together to form a case series. Okay, so for example, if you're looking for TB, if you're looking for TB in 100 patients, and if you've written a one case report on one patient who has TB, and now you have written 100 case reports on 100 patients who have TBs, now collectively it will become a case series. Okay. All right. So we are done with the four things: case control, cross-sectional, cohort, cases. What did you not understand in these four things? I want you to tell me. Come on. It's fine.
I just had one question. So, like
Yeah.
the retrospective aspect of the cohort control, for example, like we said, COPD. So, how would
Yeah.
we like? Do we just look at the people that are smoking that develop COPD, or how does that?
Yeah. So we are looking at just the people of COPD, and we will see how long of a exposure did they had in those patients to develop that particular disease. Now we
Right.
will not
Okay.
monitoring them. Now we will not monitor them to develop the disease. All right. So in prospective, for example, you are sitting right now, and there is this, smoke going on in your city, and if you start to monitor that from that particular point up to the 5 years. So right now you don't have COPD, but you monitored the entire disease progression until the very end. All right. In retrospective, the patient already has COPD, and now you're going in the past and seeing how long did it take for the patient to develop COPD. Okay.
Yes, got it. Thank you.
All right. Okay. Is it clear, everybody?
Ma'am, and related to case control and retrospective cohort, like what exactly is the difference from like retrospective cohort and case control? Like both of them are retrospective studies, but
Mm-hmm.
the case control does not have is not associated with any discussion in terms of risk factors. Is that all, ma'am?
Yes, exactly. So case control will not have risk factor. We will not have a risk factor. We will not have an exposure. For example, case control will be like, there are 100 people. All right. 100 people have TB and 200 people do not have TB. What type of study is this? All right. So that will be
Case
case control.
Listen to me.
Exactly. So you did not give the risk factor. For example, if I see risk factor is immigration. All right. If I added something to it, that, oh, the risk factor is immigration. For example, a lot of immigrants who are coming to United States, they have tuberculosis. All right. So if I add any of the risk factors, then automatically it will become what? A cohort. All right. If it is happening in the future, then that's prospective. If it is happening in the past, then that's retrospective. All right. In retrospective, remember, I will tell you this, that in retrospective, we go, so this is the disease, and we will go back in time to see the risk factor. All right. If we are going back in time to see the risk factor, that's retro. All right. But if we go from the risk factor to the disease, then that's prospective. All right. Is it clear now?
Yes, yes, ma'am. Thank you so much.
Okay, okay, got it. All right, now we come to the second thing, which I really enjoy, teaching, and that is sensitivity, specificity, positive predictive value, negative predictive value. All right, so this 4 by 4 table, who knows this 4 by 4 table? Are you guys familiar with it?
Yes.
All
Yes.
right, okay, very good.
Yes.
Okay, all right, so let me just finish it off and then I will try to explain you. All right, so this is positive, negative. This is again positive, negative. Over here, we see the test. This is always the test. Over above, we always see the disease. Okay. All right. So what do you mean by true positive? Come on, guys. What do you mean by true positive? What is true positive?
That
The
Those
we
who have
actually
the
put the
disease
test.
and in which the test is performed and it shows also the positive result. So it means they are
Very
actually
good.
having the disease.
Very good. So you have to memorize this 4 by 4 table. Whenever you are sitting in your exam and you will be given a board to draw your tables and formulas onto that, you will also be given a marker. All right. As soon as you enter the examination hall and you're given the board, just make this 4 by 4 table first. All right. Write all these values: true positive, false negative, true negative. So on the upper section, the disease comes. For example, positive means if you have the disease, negative means if you don't have the disease. And over here, you see the test. For example, if a patient, for example, let's just assume TB, all right? If this patient has TB, and there is this test known as IGRA. Are you all familiar with IGRA? The quantiferon. Are you all familiar with that?
No.
No? Okay. Just it's a test that we do for tuberculosis confirmation. Okay. It is a test that we do for tuberculosis confirmation. It's a quantiferon that we use for TB confirmation. It's just a test to see if we have TB or not. Okay. So, for example, if there is this patient who has TB and there is this test that we do to see that if the patient actually has TB or not. If the patient has TB, but on IGRA or on the TB skin test or whatever it is, we see that there is actual positivity of the test too, then that is referred as a true positive, which means that the patient actually has the disease and the blood test is also positive. All right. So both of them are positive, then that's a true positive. If the disease is negative, but the test shows that it's positive, then we say it's a false positive, right? Because in actual, we do not have the disease, but the test is showing that it's positive, so it's a false positive. All right. If we have the disease and the test is negative, then that means it's a false negative. It's kind of very self explanatory, right? If you can go through it, it's very self explanatory. And if the disease is negative and the test is also negative, then that's actually a true negative, which means that the disease has been ruled out, that there is no disease in the patient. Okay. Another, if you find it a little confusing for TB, I can give you another thing to you guys to understand. Anemia. All right. For anemia, what test do we check?
HB level.
HB level. Very good. Let's just do HB level. All right. So if the patient has anemia and on the HB level or on the CBC, we check for the CBC, right? Or on CBC, there is no anemia. Then what will it be?
False positive.
Very good. What if there is no anemia and on the test there is hemoglobin level is also normal? Then what do you mean by that?
True
True
negative.
Honestly,
positive.
too
True
positive.
positive. True positive.
True positive. Very good. True positive. So you see how basically the words have been integrated into this 4 by 4 chart. It is very easy. All right. So do not confuse yourself whenever you see this. Okay. So I am eradicating this. All right. It will look very confusing. Let me go. Let me just cancel this. All right. Okay. So this is the disease. All right. And this is the positive. This is the negative. This is the test that we see. And this is positive. This is negative. Let me just erase this. Okay. Got it. All right. Down, there are 4 arrows I want you to be familiar. This down arrow, this up arrow, this arrow, and this arrow. These four arrows are defining something. This down arrow, what does it signify? Come on, anybody.
Sensitivity.
Sensitivity. Very good. This down arrow is the down arrow. It's sensitivity, right? It's going down. So automatically you have the formula for sensitivity. Now, what will be the formula of sensitivity? Come on, guys. You need to tell me what's the formula of that.
True
True
positive
positive.
divided by true positive plus false negative.
Very good. So you see, now it has become very easy for us. We only need to memorize this 4 by 4 table with positive and negative over here. All right. This is a disease. This is a test. Four arrows are very important. This down, upward, and then towards the left, towards the right. These arrows are very important. Sensitivity is going down is equals to true positive over true positive plus false negative. All right. Which arrow is the specificity arrow in this?
Going up.
Upward.
The going,
Up
the
going up.
going up, very good. So
Going
now
up.
we know that specificity is what? We know specificity is now true negative over true negative plus false positive. All right. So we don't have to memorize these, boxes. We don't have to memorize formulas. We can, easily get it from this chart. So this chart is very important, as I told you. All right. Okay. Uh, so this upward is positive predictive value because it's right. It's going towards the right. So right is always right. Right is positive. So that's positive predictive value. And going towards the left is a negative predictive value. Okay. Now, what do you mean by, let me just write the positive predictive value formula. So positive predictive value formula will be true positive over true positive plus false positive. Okay. All right. Okay, that's the formula for that. Negative predictive value, let us see. It's going this way. So true negative over true negative plus false negative. Okay. So these four formulas are very, very high yield for you in terms of USMLE STEM 1. Forget everything related to biostats. But these formulas, if you have memorized and if you've cracked that, then you have cracked half of the biostatistics. That is how important they are. All right. Now we are going to dive into the definitions of that and what they actually mean. All right. So what do you mean by sensitivity? What is sensitivity?
The ability of the test to identify the true positives in a disease of group of people or anything.
All right. Anybody else? Is only one person participating?
To identify people who have the disease, correctly identify those people who have disease, who are with
Very good.
disease.
Exactly. So sensitivity identifies those people who have the disease. All right. Now, if we go down and we just write sensitivity is people who have the disease. All right. Who are disease positive. All right. It correctly identifies that the people who have disease. All right. What does specificity mean?
To correctly identify who do not have the disease.
Exactly, to correctly identify who do not have the disease, all right? Who do not have the disease, okay? What do you mean by a positive predictive value?
To basically tell that what is the likelihood that the test can be or a disease can be positive in a person.
Exactly. So it's basically the likelihood. Whenever you see likelihood on NBME, USMLE step 1, UWorld self-assessment, likelihood always means positive predictive value. All right, or any sort of predictive value. If they say there's a positive likelihood, then that means it's positive predictive value. If they say that there is a negative likelihood, then what does that mean?
Negative predictive value.
Very good. So you see how the words are very self-explanatory. You don't have to, dive into it. But when you go through first aid, you must find it so difficult. Oh my God, these formulas, they're so hard. I cannot memorize them. But when you actually dive into the basics of it, it's very easy. All right. There is another thing about sensitivity that I want you to know, that it rules out the disease. What does that mean? It means that a highly sensitive test will mean
That it will rule out the disease that basically
Have the disease. Means
it
there is
means that Exactly. So it will mean that the more sensitive test will be. For example, if I have done a CBC, right? If I have done a CBC and that CBC is 98% sensitive, what will that mean?
That 98% of the chances that person doesn't have the disease.
Exactly. That 98% chance is that the person does not have the disease. So it has ruled out the disease. All right. And that is why sensitivity is always used as a screening test. Okay. So whatever test you come, you always, if you're screening, you that's always a sensitive test. So any screening test you do must be highly sensitive. All right, it must be highly sensitive to rule out the disease. Okay. For example, I will give you another example of that. For tuberculosis, you do two tests. First, you do the tuberculin skin test, and the other you do is the eye graph. All right, but because you guys are not aware of that sort of test, then I will do something else. For example, for colon cancer, you do colonoscopies, right? And then you take a biopsy. So for why do you do colonoscopies? Why don't you
For
just
the
biopsy it
Rule
first?
out.
screening
Because
purpose.
exactly, for the screening purposes. So colonoscopies are highly screening test, right? And what else are screening tests? Like survey, like pap smear is a screening test. Colonoscopies are, screening test. Mammogram is a screening test. DEXA screening is a screening test. All of those are screening tests. And why do we do those screening tests first? Because they are very highly sensitive. And that means that if they are greater in positive, then that means that the person will be excluded out. The person will not have the disease. All right. Now, what does specificity mean? It rules in the disease. All right. So if I say that the person has around 99% of specificity, what does that mean?
That means that 99% he don't have the disease.
He didn't or he did?
He,
He did.
99% he does have the disease.
Exactly, 99% he has the disease. All right. And that is why those tests are done after the screening test because they're very specific. If you have difficulty in remembering, just remember that specific is a very, disease oriented term, right? For example, we will only do a specific test for a specific thing, right? For example, if that person has cancer, then we will only,
Biopsy.
specifically biopsy the colon. We will not specifically biopsy the entire body. All right. So it's a very specific thing that we are only, specifying it to a particular thing. We are not doing it as a generalized thing. Okay, so if it is specific, if it is highly specific, then that means there is a greater chance of that person of having a disease, and that is why it has ruled in the disease. For sensitivity, it meant that it ruled out the disease. If you are, 99% sensitive test, if it means that 99% chance that you do not have the disease, it ruled out the disease. So this is ruled out and this is ruled in, and that is why it's very important that you understand the concept behind it. What do we use for the screening test? It's sensitivity. All right. Screening tests are always highly sensitive in order to work. All right. And after sensitivity, then we check for the specificity. Okay. So this is number one always, and this is number second always. Got it?
Yes.
Yeah, now I get it. Thank you.
Okay.
Yes.
Very good. All right. What do you mean by, okay, so we discussed what positive predictive value means. Or so what does this mean? For example, if I'm saying there is a 98% chance that this thing has a positive predictive value of 98%, what does that mean?
So it's correctly identifying that he can have the disease.
Yes,
98.
this patient actually has the disease.
Likelihood of having the I think disease. he has more probability.
Yeah, very good. What else? Come on. What else does it tell us?
Tells us the
Prevalence.
of a
Very
disease.
good. Prevalence. So, prevalence, like we discussed, prevalence tells us the frequency of a particular disease in a population, right? For example, if we say that, smoking is very prevalent in the Asians, what does that mean? That a greater number of people smoke in Asia. That means that, right?
Common.
So,
Yes.
exactly. So, prevalence means the greater number of frequency of people having that disease. All right. This prevalence is only affected by one thing, and that is the likelihood. All right. Now, we suggested that the likelihood can be either positive or it can be negative. Positive means positive predictive value, negative means negative predictive value, right? So, if we need to increase the prevalence, then we need to increase the
Positive predictive.
very good positive predictive value. So, prevalence is directly proportional to positive predictive value, whereas prevalence is inversely proportional to negative predictive value. You understand? So the prevalence can either increase or decrease based on the likelihood. Okay. If it's a positive likelihood, which means that it's, positive predictive value we're referring to, then it will have a direct relationship. That means that if we increase the positive predictive value, the prevalence will increase and vice versa. And if, they're referring to a negative thing, then that means that there is an inverse relationship between prevalence and negative predictive value. So if we increase the prevalence, negative predictive value will decrease. All right. And vice versa. Understood? Is it clear to everyone until here?
Yes.
Yes.
Okay, very good. All right, then we go down and I will teach you this thing which, sometimes students find it hard, but I think you guys are smart, and I'm very bad at drawing, as you guys can see. Okay. Uh, all right, let me draw it. This is false negative. This is false positive. This is true positive. And there are 2 points. Let me say, for example, this is A, this is B, this is C, this is D. All right. Now, this is the graph that they give in, USMLE step 1. They won't label it, but they will just give this graph without these values that I've written in, right? So you have to memorize these values. That this is true, this area is true negative, this area is false negative, this area is false positive, this area is true positive, right? So you will have to memorize the labels of it, but they will just give you an empty graph like this. Okay. Now they will say, what if we go from B to C? What will happen? What if we shrink the graph from B to C, which means the false negative is getting what?
Will be increasing if we go from B to C.
See, the specificity will increase and increase the positive predicted value
All right. Anybody else?
and decrease sensitivity and decrease the negative.
Okay, I'll make it easier. I think this will look confusing. I'll make it easier. What if we go from C to B? Then what will happen?
Now the false positive are getting increased. If we are moving from C to B, false
Very good.
positive are increasing
So the
and
specificity will
false negative are decreasing. Yes.
So what happened is that so in this, what's happening is that if you're going from C to B, the false positive is getting bigger, right? And the
yeah.
false negative is getting crushed. Okay. For example, now I'm reducing this line. Okay. If I said that we are going from C to B, then that means we have come here, right? And if we have come over here, then that means what happens? So this was a false negative. False negative decreased and false positive has increased, right?
Yes. Yes.
So if we go up and see that if the false positive increase, then what happens? Let me just see it over here. We are going to discuss it in a lot of things. If false positive has increased, right? This is wait, oh yeah. Sorry. This is, if we're referring to the positive predictive value, if the false positive has increased, then what will happen with the positive predictive value?
It will decrease.
Will
Very good.
decrease.
It will decrease. All right. The other thing that we referred it over here was the false negative, that the false negative will decrease, right? So if the false negative over here will decrease, then what will happen to the negative predictive value?
Will increase.
It will increase. Very good, guys. Very good. All right. Okay. And then over here, the false negative is again decreasing. Then what will happen?
The
What will happen to the sensitivity?
it will increase.
The sensitivity will increase. All right. And the false positive was here. The false positive is over here. Again, if it is increased, then the specificity will
Decrease.
Decrease.
all right. So this is how you have to do your solve your problems. Okay. I will be also sharing a set of questions, and we will be discussing those questions tomorrow. We will be doing solving those problems together so that you can get an idea of how the questions are presented and how you have to extract the data out of it and solve the problem. All right, because that is a difficult part. Okay, so that's clear to you, right? Now, if we go down and if I say that, okay, now I have to increase from B to C, then what will happen?
The false negative will be increasing.
Very good. The false negative will be increasing. Very good.
False positive will be decreasing.
Very good. So what happens when the false negative increases? For
The
example,
Then
negative
specificity becomes increased.
all right. Now, what happens when the wait, is it false positive? I forgot. Yeah, like no, the false negative is increasing, right? So what if the false negative is increasing?
the sensitivity and negative predictive value will decrease.
Very good. So again, you put the arrow over here and you will see the sensitivity will decrease, specificity will increase, all right? And then positive predictive value, negative predictive value will have the same outcomes, okay? All right. Is it clear to everyone until here?
Yes.
Okay. Well, how does prevalence get affected by? By what?
Directly proportional. It is directly proportional to positive predictive value.
Very good. It is directly proportional to likelihood. All right. What if I want to increase the prevalence? Then what do I do?
You decrease the false positive.
We decrease the false positive. Why are we decreasing the false positives?
Because the inverse relationship with the positive predictive value will increase, so will the prevalence.
Very good. All right. What if I want to decrease the prevalence? Then what?
Then we would increase the false positive.
Very good. Then we will increase the false positive. So positive predictive value will decrease. And as a result, the prevalence will decrease. Okay. So it's understood to everyone. Is everyone understanding all of it? Has, if there are any questions, please ask me, because we will solve the questions tomorrow and then you guys will be sitting clueless.
Yes, ma'am. Regarding the graph, I clearly understood what like you're explaining, but like how will the question or the vignette is like?
Yeah, wait. I'll show you. I'll show you. Wait. So the question will say, for example, this B point is 13 and this C point is 25. So they will go like, what if we decide to shift the graph from 13 to 25? So it will go like this, right? And what they say, what if we decide to shift the C point from 25 to 13? Then it will go like this, right? So you understand, they will mention it in the graph like this, in the question like this. What if we shift the C to B? What if we shift the B to C? Then what will happen? All right. So then you will have to go through all of this, which I told you, that what will happen to the false negative, what will happen to the false positive. These two are very important. They don't care about true negative and true positive. They don't care about the truth at all. They only want the false things. Okay. So only remember false negative, false positive, and the relationship that it has with these four values that I taught you guys: sensitivity, specificity, positive predictive value, and negative predictive value. All right. Okay, got it. Now, ROC curve, I will explain to you very one thing that I will tell you. There is nothing that you need to memorize in the ROC curve. Okay, so they will give you a curve like this. All right. And I think if there is sensitivity over here. Yes. They will mention, this graph will be given to you, so you don't need to worry that you have to memorize it. And this is 1 minus specificity over here. This will be the sensitivity. All right. Just remember, they always want the answer in which the line is very close to this line, like this. Why? Because then that will indicate maximum sensitivity of a test. All right. So what will happen? They will give you a graph like this. They will show you a dotted line. They will say this is A. They will say this is C. And they will also show multiple lines, like B. And this is like D. And they will go like, okay, which curve has the highest sensitivity? What will you guys choose?
C, C.
C.
See,
Exactly.
Closest one.
because that's
C.
the sensitivity, yes.
Very good. So C. So when whatever graph is, very closest to this sensitivity line, it will always be the right answer. 99% times it's the right answer. Just memorize this. That's it for ROC curve. Okay, this is the ROC curve. Just memorize this one thing that I have to select the answer which is closer to the line. That's it. Okay, or they can give you it in any other format. What do we have to do to achieve maximum sensitivity if we are standing at point D? Then what will you say? We will go to point C.
Yes.
All right. So they will give you this in the option. Go to point A, go to point B, or go to point C. What will you select? Go to point C. Okay, why? Because that place has the maximum sensitivity. And they always want a test that has maximum sensitivity. Why? So that they can rule out the disease. Got it? Is this
Yes.
clear to everybody?
Yes.
Clear? Okay. Now we're going to discuss two things: precision versus accuracy. What do you mean by precision and what do you mean by accuracy? Come on, guys.
Precision is that means it's very very punctual, but accuracy that means it's correct, but it cannot be. Precision could be variant in accuracy.
All right. What else? Come on, guys. What?
Means the tests are closer to the midline. Means they are closer to the central point. But in case of precision, the values are closer to each other, but not to the midline. They are far away from the midline.
Well, I will give you a very easy thing. Okay. For example, they say that we have done a test and the laboratory, the standard value was 25, right? That's a standard value. That's like an international thing that the standard value is 25. And now we have done a test which is like 18, 12, 15. Is this a precise test?
No.
And I'm giving you another option. This is option number 1 that you guys had. The second option, they said that now we again did the test and now the values are 24, 23, and 22. Which of them is a precise test?
The first one.
Second one. Precise will be the first one, and the accurate will be the second one. Because that is more closer to 25.
Okay, very good. What will be the precise test?
Yeah, precise
Precise test will be first, and accurate will be second.
second. Yes.
Very good. So you see how they give you the values and they will ask you what's that. So precise is closer to the number or the value. Accurate, the thing I will tell you again. Precise can be accurate too. All right. That is what I wanted to see. You guys are getting confused. Precise can be accurate too. Why cannot it be accurate? I mean, if the test came closer to the standard value, then it can be precise and it can be accurate. Now, if I had given you any other option of like 22, 12, 14. Then what? Then what option will be the precise one and accurate?
This is precise.
Very
Not
good.
This is
accurate.
precise
Yeah.
This is
because two
precise.
values of it is
This
closer
is
to the
not
mid.
accurate. This
Ma'am,
is accurate.
but won't it be again like it is low precise because being like again we need to decide if it is high precise or low.
I think because less numbers are closer to 25, so it's less precise. Whereas 24, 23, 22, they're more accurately closer to 25.
Yeah, okay.
All right. Okay, very good. Yeah. So again, precise, you know what it is, and accurate, you know what it is, right?
I'm sorry, Dr. Maheen, I'm not getting the concept.
Okay, let me just go again. What if the standard value is 23 and we did a test where we got the value of 23, 22, 21. All right. And we did another test. Wait, let me just rephrase it so that you guys can have a better clue. All right. Okay. It's 23, it's 15, and it is 17. And then we did another test that is 21, 22, and 20. Which one of them is precise and which one of them is accurate?
The second one will be highly accurate
Yes.
because
The
the
first.
values are more closer to 23. And the first one is highly precise
Precise.
because the two values are more far away from the 23.
Very good. So this is precise. Why? Because the values are far. Now, it means that it was precise, yes, that the values were, kind of there, they were jumping around, but they aren't accurate because the standard unit is 23, right? So we have to be closer to 23 in order to be accurate, right? What does accuracy mean? 100% or 99% closer to the original value. That means it's accurate. So whatever value will be closer to the original value will always be accurate test. Okay? And the other test will automatically become precise.
Excuse
Got
me,
it?
ma'am.
Yeah.
There is this diagram given in the first aid, like
Hmm.
it is a third diagram where only one, like out of the four reports, only one value is extremely close to the original report value, and rest of them are deviating. Yet it is given highly accurate, ma'am. Ma'am,
Yeah.
like the one which you have mentioned first, the 23, 15, and 17 one, the similar graph has been given in the first and the third graph.
Oh, yeah, you're right. Wait, sorry. This is the upper one is accurate. I'm really sorry. This is accurate.
Yes.
Yeah, this is accurate. And the precise is, wait, let me see. Yeah, the precise is this, the second one. You guys are confusing me too. This is precise. This is precise. Yeah, I'm really sorry. I apologize. All right. So
Right.
now I'm saying that why is it accurate? Now, accurate is when you have the value of it. All right. So this is 23, this is 23. And if you do it on a bullseye, so this is we need to hit the bullseye over here, right? And if I hit a bullet over here or here, then this will be accurate, right? Because near the bullseye, I have hidden the bullet. But clumping of the
Dr.
text
Maheen.
together will tell if it is precise or not. All right, which means they should have lesser distance in between them. Yeah, sure. Go ahead.
But Dr. Maheen, look at the first picture.
Dr. Maheen, I
Yeah.
guess 21, 22, 20, it's precise and accurate. It's both precise and accurate.
Yes, yes.
But 21, 22, 20, these three values are highly accurate because they are hitting the
Yes,
bull.
yes,
But
they
Raj,
are highly
23,
accurate and highly
23 is more
precise
closer to
than
25.
23, 15, 17.
Excuse
Yes.
me, just let me quote that the 21, 22, 20, those values, since they're close to each other, they're also precise. yet they are near to this value of the, like near the main value of 23, they are also
Yes,
accurate.
exactly.
So it is both
I support.
accurate and precise. That second
Yes,
one
yes.
is. Yeah.
Okay, let
Yes,
me
I
let me just wait. It's
yes.
getting very confusing for you guys. So to this, you guys are confusing me as well. You guys are confusing my concepts as well. Let me just do it 17, 18, 19. Okay, and let me just change this to wait. Let me change this to 20, and let me change this to 18. Now is it better? Now you guys understand?
Yeah, it's better now.
Yes,
Yes.
Now,
now
Yes.
now the 17, 18, and 19 are more precise
very good.
because they are
More
And
closer
precise
to,
and accurate both.
but
Both.
far away from the actual.
very good. Yeah. So that's what I'm saying, that let me just put 21 over here so that you guys can, now is it okay for you guys? So I will tell you
Yes.
a very
Now,
clear
what
Absolutely.
will
way.
be the first one? 23,
You
20,
wait,
and
I
21.
will
Is
tell
this
you that
accurate
how
or
will they ask
precise?
questions. So you guys are confusing. They will never ask you that if this test which is precise, is it accurate also? They will never ask you that. Okay. They will only ask you which test is more precise and which test is more accurate. And they will want you to list those tests in a in the bullet form, right? So for example, if this is an A test, let me just say, and this is a B test, right? This is an A test, this is a B test. They will say which of them is, more accurate. Then you will say the A test is accurate. So A for accuracy, and they will ask you which of them test is more precise. Then what will you say?
It's B.
B.
B. So,
B.
so it's be precise. And then you will have to click on option number one that will be containing these both answers. All right. So this is how they will ask you. They will not ask you that if the accurate test that you have selected, is it precise also? They will not ask you that. Okay. So do not confuse yourself. This is not a confusing topic. All right. Just remember that those tests that has values nearer to each other, they do not have that much of a jump in between them. Those are more precise. All right. Now, precise tests can be accurate, but for the sake of, borderline understanding, just remember that the more the values will be grouped together, the more the values will be nearer to each another, those will be more precise. Now, they can be accurate and they can also not be accurate. For example, if the value was 45 and you get 17, 18, 19, then these are not accurate tests, right? But they are precise because they are close together, right? But what if I'm saying that the value is 20? Then they will be both precise and accurate. Okay? Understood? Is it clear now to everyone? More the
Yes.
values are closer to each
Yes.
other, that means they're more precise. Now, those precise tests can be accurate depending on the standard value. If they're also nearer to the standard value, then they can be accurate. If they are very far away from the accuracy value, then they're only precise. Okay. So accurate test is that test which value is nearer or exactly that. Okay. That is always accurate, irrespective that they have the other values are closer to it or not. We will say that it can be an accurate test. Now, for example, if it is 23, 20, 21, then we can say that, oh, it can be a precise and it can be an accurate test too, because the values are not that far. But if from 20 and 21, I replace it with, for example, 7 and 45, then will it be a precise test? No. But will it be an accurate test? Yes, because of 23. Understood? Is it clear to everyone?
Yes, ma'am. Yes.
Yeah.
Yes.
Now, I think now I've made it clear. You guys were confusing me with all of this. Okay. So, all right. Okay. Now let us move on to the other thing, incidence and prevalence. What do you mean by incidence and what do you mean by prevalence?
Incidents are the new cases, and prevalence are the cases which are already present in the society.
Very good. This is very easy. Number of new cases. So, number of new cases divided by number of people at risk. All right. Number of people at risk. What do we see in incidents? Incidents is, looking at the new cases. Incident looking at the number of new cases. All right. And what does prevalence mean? Come on, what
All
does
current
prevalence mean?
Who've
cases.
been
Exist.
All
had
current
the
cases
All
disease.
the
described.
existing cases.
All the existing cases, including the new cases as well. All right. All the cases. Got it? Including the number of new cases. So, for example, if I say that if I say that the prevalence is greater than incidence, why? Because
Because
of
tra-
chronic diseases, right? So, if for example, diabetes mellitus is a chronic condition, right? So, more prevalence will be there. Why? Because a lot of people already have the disease and it is not getting, young people are not getting more diabetes mellitus. So then what will happen? Prevalence will be greater than incidence, right? But if I say that more people are getting diabetes mellitus, then what? More new people are getting diabetes mellitus, then what will happen?
then incidence will be more.
Then
Incidence will
incidence will. All right, you got it. But again, that's what I want you to realize, that incidence will never be greater than prevalence because it's a subset of it. Prevalence is the mother, all right, and it's the mother, all right. Incidence is its child that is being born over time. Very bad example, but you guys get the idea, all right. Born over time, it is not there in the present, right? It wasn't there in the past, but prevalence is the mother, it's there at all times. Okay, incidents can develop over time, you understand? For example, I'm saying like chronic conditions, or just let's just say SLE. All right, for example, SLE was there. So what will happen is, in 2008, we did a survey of people who had SLE. All right. Now we're seeing all the people who had SLE in 2008. In 2009, we now saw that there were 15 more people added to the case. Then what will happen? Then the prevalence will also increase, right? Because the incidence, if it is increasing, then the prevalence will also increase, right? How can just the incidence increase and prevalence not increase?
Yes.
All right. When will prevalence and incidence become equal? What time will it be?
For short-term diseases.
Very good. When incidence is very short, for example, cold,
Yes. So
right?
for this can be.
So incidence can be equal to prevalence only when the incidence is very short lived. All right. In cases of a cold. All right. So incidence can be equal to prevalence if it is very short lived, but incidence can never be greater than prevalence because prevalence is the mother. Just remember this, prevalence is the mother, incidence is the child. Incidence can try to be, equal for a short period of time, but even after a certain time, it will go below prevalence. Okay. Now I told you guys that prevalence depends upon what? Likelihood. All right. So if you want to increase the prevalence, then what will you do?
Positive predictive value will be increased.
Is also predictive value.
Increase the positive. What if you want to decrease the prevalence? Then what?
Decrease the positive predictive value or increase the negative predictive value.
Mhm.
All right, very good. So it's very clear. Now, if you guys do not understand anything, please ask me.
Ma'am,
And
regarding thing in first step, there is this equation given prevalence upon 1 minus prevalence is equal to incidence rate into average duration of the disease.
no,
Do
you
we
don't have
need
to
to
memorize that. No need to memorize that. Whatever I'm teaching you, just memorize that. That's it. Your biostatistics will be done. No need to memorize that equation. They don't ask you that. Okay.
okay, ma'am? Thank you so much.
All right. Okay. So is it clear to everybody, you guys? If you want to ask anything, then please ask me so that I can move forward with one to do more things. I want to clear the odds ratio and relative risk that we discussed earlier so that you guys can have an idea of what that is. All right.
Yes,
Okay.
it's
All right, so it's clear to everybody, right? Okay. Then we are going to the next thing, and that next thing is odds ratio and relative risk that we discussed earlier. Where do we see relative risk in? Where? Where are two relatives? Where are two O's found?
Cohort.
Cohort study.
Cohort. Very good, guys. Cohort. Odds ratio, two different people. Where do you see that?
Case
Case
Yes.
control.
control.
Case
True.
control. Very good. Now, what does odds ratio mean? What does odds ratio mean? Can anybody tell me what is odds ratio?
It's simply a comparison of one group with the other, like the odds of having a disease.
Yeah. So now what I want you to remember is just one thing. And that one thing is, what if odds ratio is greater than 1? What if odds ratio is lesser than 1? Okay. Or what if odds ratio is equals to 1? Now, what do you mean by odds ratio greater than 1? What is this?
The chance of having the disease are high, like
Very good. Very good. The chance of having the disease is high.
yes.
Okay. What if the odds ratio is less than 1? The chance of disease is
That
less.
means the protective effect actually. Like something is
Yeah.
the protective effect.
Yeah. It's a protective effect. Or you can also say that the odds of exposure are greater in control, right?
Yes. Yes.
What if odds ratio is equals to 1? Then what?
No, no effect basically.
Then what?
No effect. No effect.
No
Like
effect. So
there's
this we also say as null value, right?
yes.
Because this does not have any significance. So whenever odds ratio is equals to 1, then no effect because it is equal. All right. So this means null value, it will cancel out. So what I want you to remember over here, that whenever they give you this in any paragraph where they're giving you this statement, odds ratio is greater than 1, I want you to know that they're saying that the person has high probability or high, chances of having the disease. All right. If they're saying that the odds ratio is less than 1, then there's a less chance. If odds ratio is greater than 1, then no effect. Then I want you to click on the option no effect because it is null. It cancelled out the effect. Okay. Is it clear, guys?
Yes.
All right. Then we go to the relative risk. What do you mean by relative risk is also like odds ratio. Okay. So what if relative risk is greater than 1? Then what?
So the
It
chances
means
of one
that exposure
compared
is
to other is
associated
increased.
with disease.
Again, exposure is associated with increased disease occurrence. Okay, because we talked about that in cohort, we will always look for exposure and risk factor. So exposure is, kind of increasing the risk of disease occurrence in this, right? In relative risk less than 1,
So
exposure is doing
Exposure
what?
is less.
decreasing
Yeah.
the
Decreased disease occurrence. Yeah.
Very good. Exposure is associated with a decreased disease occurrence. Relative risk is equals to greater than 1, is equals to 1, then what?
it is causing nothing. No effect.
Nothing. Null. This is also null.
Oh,
All right. So this means null, no effect. So whenever you see relative risk equal to 1 or odds ratio equal to 1, that means
That no
no.
effect is taking
Heck.
place.
null. No effect. No
No
association.
exposure and no infection.
No association. All right. Uh, Not significant. Okay, these are the four terms that they can use in your paragraphs. All right, it can be null, it can be no effect, it can be no association, it can be not significant. Okay, is that clear to
Yeah.
everybody? All
Ma'am,
right,
so,
yeah,
exposure per se, like, are they talking about the risk factors?
yeah. Exposure is risk factor.
Okay, okay.
Okay, exposure is similar to risk factor. There is nothing different. Now, I want you to memorize the formulas. I hate about it, but unfortunately, again, there is a 4 by 4 table over here. All right. And this is, let's A, B, this is C, this is D. Okay. Now, this is a different table than the sensitivity and specificity we done. So please pay attention to this. All right. This is positive, negative, like in everything we see, right? Over here, we see the disease or we see the outcome. Okay. On the y-axis, we check for the exposure. All right. Or you can say the risk factor. Okay. Is it clear? So this is the disease portion, this is the exposure portion. So now odds ratio will be what? Can anybody tell me the formula of odds ratio?
It will be A upon C upon B upon D.
Very good. Okay, so what will they give you? They will give you a paragraph in which they will give you, for example, there are 50 people who had the disease. Okay, they will give you, for example, 50 people had the disease and 20 people did not have the disease, right? 50 people had the disease, 20 people did not have the disease. Then they will say that around from 50 people, there were 25 people who had the exposure and 25 people did not have the exposure. Okay. From 20 people who did not have the disease, around 10 people had the exposure and 10 people did not had the exposure. Then how will you, do the then how will you form this chart? How? What will the
Like it's
values be?
one.
One? No,
We will
I
basically
want you to
identify.
tell me, like, for example, if it is A upon C, so that will be what? 25 upon?
A is the 50
25.
or
No,
10.
50 is the total number.
total number?
A is
Okay,
25, right?
25.
Right?
25 over 25
It will
Yeah,
be
okay.
25 upon.
divided
Again,
by
10 over 10.
Divided by
Divided
10 over
on
10.
10 by 10. Yeah.
Okay. Now, if we see 25 over 25, and then we divide by 10 over 10, and then we go down, we see 25 over 25 multiply by 10 over 10. It goes reciprocal, but because the values are similar, so, they're same over here. Now, what will happen? 5 twos are 10, 5 fives are 25, 5 threes are 10, 5 fives are 25. That will be 10 over 10. That will be 1. Then that means odds ratio is 1. That means what?
No effect, nothing.
No
No.
effect. Understood, guys?
Yes.
No
uh,
effect.
I just have a question about the 10. What did you
how we
say?
get
Like, how did we get the 10?
What 10?
The tens that you put on the side. Like, what
Yeah.
did you
So
say for
there
this?
will be, there will be a question, and that question will be very big, and they will say that, for example, there were 50 people who were, who had the disease of bronchogenic carcinoma. All right, there were 50 people who had the disease of bronchogenic carcinoma, and 20 people did not have bronchogenic carcinoma. Out of the 50 people who had bronchogenic carcinoma were exposed to asbestos. All right, and 25 were not exposed to asbestos. Okay, out of the 20 people who did not have bronchogenic carcinoma, 10 people were exposed to asbestos and 10 people were not exposed to asbestos. So, what will be the odds ratio? Then you have to form this graph. You will have to divide the numbers. You will have to put it, in the chart, right? And then you will have to form this table of odds ratio. And then you have to put in the values and see what is the odds ratio. Okay. And if the odds ratio is equal to 1, that means no effect. If the odds ratio will be greater than 1, which means increased chances. If the odds ratio will be lesser than 1, then it means decreased chances, right? So they will give you a question like this. You have to split the values yourself. And that is why I said that I will give you the questions tomorrow so that you guys have an understanding on how to solve this. Because solving is the important part. Okay?
Yes. Thank you.
Yes.
Is it clear to everybody? You have to put these values to yourself. So they will give you in a graph form or in a paragraph form, and you have to, automatically divide. Okay, so this means disease. 50 people have disease, and 25 were exposed. Okay, this will value come over here. Okay, and out of the 50 people, 25 were not exposed. So 25 plus 25 is 50, right? 10 plus 10 is 20, right? Okay. So this was the entire chart of odds ratio. Then we will do relative risk. What is the value of relative risk? Can anyone tell me?
It is basically A upon A plus B upon C plus D.
Very good. So it will be A upon
Upon A
A
plus
plus B divided by C
C.
upon C plus D. Now, considering the values what we have already put above, so it will be 25 over 25 plus 10. Okay.
Yes.
And this will also be the same, I think, right? So this will
Yeah.
be 25 and 25 plus 10. I think that will be same. C is 25, I think. Yeah. All right. Okay. Again, we will divide it like this. Divide by 25. 25 plus 10. All right. 25 will be, and then it will be 35, right? My math is very bad. That is why I'm in medicine. And don't worry, the calculator will be given to you, so you really don't have to like really worry about it. And then when you reciprocal it will be 35 over 25. Cancel, 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 cancel. So the relative
One
risk will be equal to
Hang on,
1.
you,
equal
That
to one.
means no effect.
Reston, hello, Reston, please could you get your, we are getting a lots of distance.
Yeah, what? Are you referring to me?
No, ma'am, there is like one
Got you,
person.
brother. Got you.
Okay, yeah. So this I will give you 3 to 4 questions tomorrow so that you guys have an idea of how to solve this. Okay, don't worry about it. The other thing we are going to do is, so now you have an idea of what odds ratio is and what's relative risk. Okay, now I want you to also memorize, unfortunately, 3 to 4 other formulas as well, which I hate, but there is no way. That is called as relative risk reduction. Now, what do you mean by that? What do you mean by relative risk reduction? What is this?
Like it's if there are diseases developing because of any risk factor or exposure, and if they are trying to counter it with something, so they are basically calculating that what will be the relative risk reduction.
Yeah.
While cessation of smoking, how much can it decrease the rate of lung cancer in a subset of patients?
Very good. You're absolutely right. Again, the proportion of risk reduction attributable to the intervention, and it is divided by the attributable risk treatment as compared to the ARC. So what you are doing is that just don't remember the formula of it. Sorry, don't remember the paragraph form of it. Just remember the formula. So relative risk reduction is 1 minus RR. Okay. Now, what you have to do is, if you know the relative risk, what we discussed earlier over here, you can just do 1 minus relative risk. For example, if they say that the relative risk is 75%, how will you put it over here? You will say 1 minus 0.75. All right. So they will always give you relative risk in the form of percentage in the question. In relative risk type questions, okay, they will always give you, okay, the relative risk is this percentage, and find out the relative risk reduction. Then what will you do? 1 minus point. Why? Because 75 divided by 100 will be what?
0.75.
0.75. Okay. So the relative risk reduction will be what? 0.25. So
Right.
what will you do in the answer? 25%. Got it?
Yes.
It's clear? Just remember relative risk reduction. They will give you that the relative risk already, or you have to find the relative risk through the above chart that we did, right? Once you find out the relative risk, you will put it in the point decimal form. You will get the answer, and then you will again convert it into the percentage. And that will give you the answer of relative risk reduction percentage. Okay, that's
Yeah.
that. All right. Don't worry, I will tell you how to solve these. Another thing they ask you is this ARR. I think, yeah, they ask ARR. That's absolute risk reduction. Now, what does this mean?
It is basically the control rate minus the treatment rate.
Very good. Very easy. This absolute risk reduction is the very easiest. It's event control minus event what?
Treatment.
Treatment. Very good. And this again will also be coming in a percentage form. So whatever control you will be having, you will minus it with the event treatment, or you can, control can also be placebo in such cases, right? For example, they say that we have done 2 trials. One of them is placebo. So you will put placebo values over here because it will always be the main control, and the treatment, the actual trial that you're doing will be placed over here. The actual trial. Okay.
Yes.
And you will minus it, and it will come in a percentage form. Don't worry, I will teach you guys how to do it yesterday as well. I just want you to be familiar of how we are going to take things from here. All right. What do you mean by number needed to treat?
It is basically the formula is 1 divided by the absolute risk reduction,
Hmm.
and it
What does
means
this mean?
in the whole scenario, like if they are treating a group of people, so they basically ask us to find that what is the number needed to treat a certain disease. So like how many people can basically recover or not, something like that.
Very good. So number needed to treat is the number of patients who need to be treated for one patient to benefit. All right. For
Yes.
example, if I'm saying that I have done a test on 40 people, all right, or if I have given acetaminophen to 10 people for headache, right? Out of those 10 people, only 2 people got cured. Then what is the number needed to treat in this case?
um, Not sure.
Ma'am, could you please repeat the question
So the
again?
question is, I gave 10 people Panadol for headache, right? They were having headache. So I give them Panadol, acetaminophen, and out of those 10 people, only 2 people got treated and their headache got resolved. So what was the number needed to
5.
treat in this?
It will be 5.
Very good. So you divided this 2 divided by 10 and it will be 5. So the
5.
number needed to treat will be 5. Okay. So this is what you do is like the you put the, let's just say you give 10 people acetaminophen, you give 10 people Panadol, right? And out of that, only 2 people got healed by that Panadol. So that means that you have to at least treat around like 5 people to get a good result out of 10 people. All right. So that is why you divided it. Don't worry if you don't understand, it's completely okay. I will tell you tomorrow how to do it. All right. So just remember what the ideology is behind it. And this formula is very important. Number needed to treat is equals to 1 divided by ARR. They will always give you the ARR in the paragraph. All right. They will always give you the ARR in the question. What you have to do is just 1 divided by the number and you will get the number needed to treat. Okay. Very
Dr.
easy.
Maheen, could you please repeat the above one ARR once again, please?
Yeah, sure. So absolute risk reduction is equals to event control minus event treatment. I think it's not mentioned in the first aid like this, right? But I want you to remember this. Event control minus event treatment. Now, in event control, you will have always the placebo, the drug which you're comparing to, and event treatment will always be the actual trial or the actual thing that you're doing. Okay?
Yes.
All right? Easy.
Yes.
Very easy. Okay, not very easy. I will teach you guys tomorrow how to, do the questions. But I just want you to remember the basic concept of that. They don't ask you number needed to harm. They will never ask you, if you're very unlucky, they will ask you one question, that's it. And that really does not have that much significance. If you want to go through that, through the first aid in terms of definition, you can go through it, but they really don't ask you number needed to harm, okay? Case fatality rate, they won't ask you. All right. Again, if you want to go it for information purposes, then you can go through information purposes. The last thing that I will be doing today will be the biases. Okay. And then I will be conducting the class tomorrow as well. Okay. Biases. What do you mean by bias? What is bias?
Something that basically disrupt the result of a study.
Hmm. Okay. What types of biases are there? Can anybody tell me?
It can be like there are many types. The physician bias can be there, the observer bias can be present, or patient bias.
Selection bias, lead bias.
Yes.
Recall bias. Don't worry, I will tell you. Measurement bias. It can be observer bias. All right. But what high yield are two things: lead
Lead
bias
time.
and length time bias. These are very high yield for you. Okay. All right. What do you mean by selection bias? Can anybody tell me?
It- It's like very specific to like a certain thing or
Yeah.
group.
For example, that you specifically selected some things. All right. For example, there were five patients, and you specifically selected that no, I want this patient, no, I want this patient, and no, I want this patient for my trial. Okay. So out of five patients, you handpicked three patients by your own choice. Okay. Now that will create a bias because you have, handpicked them, you have purposely selected them for the trial. So that will be a selection bias. And in order to eliminate this selection bias, you will do something that is called as non-randomization. Now, what does that mean?
So you don't randomly select the people, like you are choosing from a group of the people.
It's
Will,
randomization.
will it be randomization or non-randomization?
No, it's randomization. I corrected it. It's randomization. What we did was non-randomization.
Okay, so we have selected the patients like by in a non-randomizing fashion. So here we need to do
Randomization. So that's the thing. In order to eliminate the selection bias, we have to randomly select people for the bias. In that way, we will not be aware of what those patients are, what type of problems are they having, anything related to at all. We will be completely blind. And that is why those studies which are randomized are highly, highly valuable studies. Why are they valuable? Even in terms of research, I don't know who is attending the research workshops. I don't know if you guys are enrolled, but if you guys are enrolled, then Dr. Manahil might have told you that those studies are highly prestigious, which are randomized, which means that we do not purposely select the patients to come in a trial. Why? Because then it will create a selection bias. Okay. So the question that they will ask you on USMLE is that what do we have to do to eliminate this selection bias? Then it will be
Randomization.
Random
randomization.
sampling. Yeah.
Very good. What if they ask you a question like, there was Dr. Maheen and she handpicked five patients. She handpicked five patients and enrolled in a study. Then what type of bias will that be?
Selection bias.
Selection bias. Very good. Okay. Now, recall bias, they will only ask you in terms of a questionnaire. All right. Now, questionnaire, what does that mean? For example, you guys attended a conference. Okay. Now you attended a conference and they gave you a questionnaire to fill it, right? You read the questions and you know what the questions were in there, and you kind of filled the answers as well. Now, if you come outside and somebody asks you, oh, okay, what type of question was there and how did you answer it? Okay, that will be a recall bias. Why? Because you can recall what the question was and what the answer you wrote was, right? So they will always give you a recall bias in the fashion of a questionnaire. Like they will say that, oh, these group of researchers attended a conference and they were presented a questionnaire and then they were asked about the questions and answers of it. So they had a complete a bias to it because they already wrote the answers to that question and they kind of knew what the answer was. It's kind of like cheating on USMLEs, right? Like you went and you solved the questions and you know what the questions were, what answers you put, and now you're telling those answers to everybody, and that is creating a sort of bias in their answers, right? That will be a recall bias. All right. Is it clear, everybody?
Yes.
Okay. So just remember questionnaire. Okay. They will give you a questionnaire every time in terms of a recall bias. Okay. What do you mean by measurement bias?
Like how things are like measured according to their time or something.
Uh, Anybody
In a
else?
manner, like the data is collected in a disrupted
Yeah,
manner.
in a faulty manner. Like, for example, the machine wasn't working. The machine was disorderly. Like, for example, you use a blood pressure tool, sphygmomanometer, to measure blood pressure, right? What if that sphygmomanometer was malfunctioning? Then it created a measurement bias in that, right?
Yes.
Are you getting me? Okay. Then
Yeah.
we get any observer bias. What do you mean by observer bias?
It's actually the person who is conducting the trial.
Hmm.
His beliefs can change the outcome of the result because he is inclined to one capacity of research. Like this certain something can do like this something. So his own beliefs about the research results can negatively outcome
Very
the
good.
result.
Yeah. For example, if Dr. Maheen, has come across a drug and that drug's name is NextGen Usmle. All right. That drug's name is NextGen Usmle. And I believe that, oh my God, this is so good. Everybody who comes in next in USMLE will pass USMLE step 1 and step 2 with flying colors. All right. I'm believing this. So whoever is getting enrolled over here and my study at the end of it, I will always have a bias because I believe that next gen USMLE students will always pass step 1 and 2 with flying colors. Okay, so that will create a bias in me collecting the data of how many people actually passed USMLE step 1 from next gen. Okay, so it is my own belief or anybody's own belief that comes in confliction with the actual result. Okay, and that creates a bias that is known as the observer bias. And that is why double blinded studies are highly preferred in the modern science. What do you mean by double blinded?
In which the patients are also unknown, in which group they are, the observer is also unknown. That in
Very
which
good. In which they don't know, like for example, I am Dr. Maheen, I am the observer, I don't know who's coming, and the patient is also doesn't know who my doctor is, right? So this is
yeah,
a double-blinded study. What studies are more efficacious? Double-blinded, randomized control studies, right? So now you understand what it means. Why whenever you read a research paper, it always says this one line on top of it: double-blinded, randomized control, right? So what does that mean? Now you guys know what that means, right? Okay.
yes.
All right. Okay. Very good, guys. Okay. Now we do this lead bias and length bias. What do you mean by lead bias? What is lead bias?
Lead time bias is basically that if we are detecting a disease earlier, so we think that its prognosis will be good, but it's not like that in reality.
Hmm. Anybody else?
You're just basically doing more measures to continue monitoring the disease. So that's why you know that the disease is occurring, but in reality it occurs when it needs to or when it's going to happen.
Very good.
Like prognosis is like most probably not gonna change.
Exactly. So, let me just put in screenings. Okay. For example, if I am doing a mammogram, all right, and the probability of you having a breast cancer, right? What type of bias will it generate?
It will give a lead time bias because if it is detected early, so we would think that the survival time will also increase,
Very good.
but
So you
it's not.
understand? In what so we are doing mammograms every, in after 50 years old we're doing it. I forgot the what the year was, but I think we do it every 2 year or 3 yearly mammograms in 50 plus women. So now the thing is that if we detect breast cancer early, we are thinking that, oh my God, we have improved the survival of the patient, right? Or the patient is going to live a very long life just because we have caught this cancer early. But in general reality, it does not really matter. We have just caught the disease early, right? And that is creating a lead time bias. Okay, so just remember in a question, whenever they talk about screenings, whenever they're talking about any test that is catching the disease earlier than the expected time, then that will always create a lead time bias. Okay, so just remember screenings, high yield for it. All right, they will always mention screenings for lead time bias. Sorry. Okay, now what do you mean by length time bias? Come on, guys.
I'm not sure about this.
Anybody who wants to?
I'm just gonna read. It's like a screening test detects diseases with long latency period.
Very good. Anybody else? So whenever they mention anything time related, just remember that. Forget about everything else. Whenever they mention time related, that, oh, we caught the disease at 20 and the patient became significantly worse at 60. Whenever they're mentioning time, it's always length time. Okay. And another thing I want you to remember, they will always give you in terms of chronic diseases, chronic cases, or chronic cancers. All right. Two things. First thing, whenever they're saying time, that's mentioning time in terms of years or month, that is always length time bias in USMLE. Second, they can also refer you chronic cases or cancer. So chronicity, it's going to take a long amount of time for the patient to die, right? For example, there is a rare form of, for example, there is SLE. SLE can start at 25 years old and can, progress up to like 75 years old. So what type of bias will that be? That will be a length time bias, okay? But what if we caught SLE at 21 earlier and that disease is actually, getting significantly worse at 75? Then that would be a
Lead
lead
time
time
bias.
bias. Exactly. So we caught the disease early, but it's actually getting worse at 75, what it's generally occurring at, worse at, right? So this is a lead time bias. But whenever they say that, oh, the disease was this, there's this 25-year-old patient, got diagnosed with SLE and she got significantly worse over a long period of time and then she died at the age of 75, then that is a length time bias because they're specifically mentioning you the years and the time frame. All right. And the second thing is they will always give you it in terms of chronicity, like long cancers, like long autoimmune conditions. Okay. Is it clear, guys? All right. Okay.
Yes.
Next thing I want you to remember is the Bergson bias. Now, what do you mean by a Bergson bias? And the other thing I want you to remember is the Hawthorne effect. Okay, what do you mean by Bergson bias? Just remember one word, hospital related. That's it. Whenever you see hospital related question and they're asking you what type of bias it will be, just click on Bergson bias. That's it. That's it. And if you want to know what it means, then can anybody tell me what it means?
Like it's basically a error in the selection. Like if
Yeah.
we are looking for certain exposure and disease, like we are seeing what is a connection between them. But if
Yeah,
the subjects are having different kind of exposure, so it will create a Bergson bias.
yeah, for example, I want to do a study on tuberculosis. For some weird reason, I love tuberculosis a lot, right? So, if I want to do a study on TB, and instead of seeing, type of, average ill patients, I went to the hospital and I picked patients from the ICU. I picked ICU patients. Then that will create a bias because they're already dying from, aggressive uh, problems that are happening. And that is why they're in the ICU. They're already on the deathbed. And I have gone on the ICU and said that I want to examine these patients for TB. Then what type of bias will it generate? Bergson's bias. And that is why I said whenever they are referring to you a hospital, that whenever a researcher wants to, admit or enroll hospital patients for a trial, most of the times it's going to create a Bergson's bias because those patients are already dying. Then why do you need them for a trial? They're already dying because of some other condition. Okay.
Yeah.
So what do you mean by Hawthorne effect?
It is basically like if you are evaluating that how does sedentary lifestyle or affects the development of diabetes in people aged above 40. If they become aware of this, so they start exercising more or walking more or eating a
Mhm.
healthy diet. So basically they change their behavior. So that can change the result of the study.
Or I think
Yeah.
it's like modifying behavior because somebody else is observing you.
Yes.
Yes, both are right. Participants changing behavior because they have become conscious. Just remember one word, conscious. That's it. Now they
Yes.
have become conscious. So, oh my God, somebody is now judging us. Now somebody is body shaming us for our weight. Now somebody is actually trying to achieve results. So now we have to go and hit the gym and not eat junk food and Coca-Cola and only eat, healthy salad. So that will create what type of bias? Hawthorne effect.
Hawthorne.
Because now the patient is self-aware, conscious. Okay? We don't want the patient to be conscious. Why? Because if the patient is conscious, then they will alter their behavior, which will, alter the course of the study. And that is why we don't want the patient to be conscious. And that is why you see, upward I said double blinded, that the patient needs to be blind also. Why? Because if they become conscious, then what type of bias will occur?
Hawthorne effect.
Hawthorne effect. Very good, guys. Understood?
Yes.
Very
Yes.
good. Okay, guys. So we have done a lot. Now there are some few things. Wait, I think we have got time. Let me just complete two more things so that tomorrow we can have a question-oriented class, because I feel that's really important. And I also feel that you guys must be stucking up on that a lot. So it's really important for you to confounding and effect modification. Let me do that. And yeah, one more thing I will tell you guys. It's really high here. Okay. P-value is also really important. Let me just first discuss p-value because it's very important. What does p-value mean? What is p-value?
If it is less than 0.05, so the chances of a study being correct are more.
Hmm. What else? What does p-value? What is p-value? Aside of
Yeah,
that,
the probability by luck.
probability by luck. Okay, very good. So in order to see if the study is statistically significant or not, we need to see the p-value. If the p-value is less than 0.05, then it's a statistically significant study. Okay. If it is not less than 0.05, for example, if it is 0.5, the value is 0.5, p value is 0.5, then will it be statistically significant or insignificant?
Insignificant.
Insignificant. Very good. Okay. What if the p value is 3? Then what?
Again, insignificant.
Insignificant. What if the p value is 0.01?
Then it's significant.
Then it's significant. You see, the p-value should always be less than 0.05, because if it is not less than 0.05, then it's an statistically insignificant study. Okay, then we don't need that study. Okay, so that is what p-value means. Another thing that I want to tell you guys will be confounding and effect modification. Okay, let me, yeah, okay. So what do you mean by confounding and effect modification?
The confounding basically means that if you are comparing a risk factor with a disease, so basically there is no relation in them in actual. Like in the first aid, they say that if you are drinking more alcohol or coffee, so you are basically developing lung cancer. But there is
Hmm.
no association between them. It is likely because most of the people who drink more alcohol, they are also likely to smoke more. So smoking is actually the cause of lung cancer, not alcohol itself.
Just one thing I will tell you. Effect modification is direct, confounding is indirect. Wherever you see, oh, this happened, then this happened, then this happened, then it actually went to the first point, then to the third point and fourth point. That is always confounding. Okay. When they say this happened and this got achieved, then that is effect modification. Very easy. Okay. I will tell you the examples, but for the purposes of understanding, I want you to understand that effect modification is direct effect, confounding is an indirect effect. Okay. So whenever they give you a question which they are, spinning you round like a merry-go-round, that's most likely they're referring to confounding. And if they're referring, very, very straight to the line answer, then that means they're talking about effect modification. Okay, that's something that I'm teaching you so that you can save time on USMLE step one, because it's a very lengthy paper and sometimes you do not have the time to just go through the entire question to pick an answer. So this can help you save time. Now, if you kind of go and just look at the example, then exactly he was totally right that in confounding, the factor is related to both exposure and the outcome, right? So there is
Yes.
this factor and it's related to both the exposure and the outcome. Okay. So what can be the factor in this case or in any case
In the confounding or effect modification?
in the confounding?
So, like we were saying that the factor was alcohol or coffee or something like that,
Yeah, you're right.
and the outcome was lung cancer.
Yeah. For example, if you are saying that uh, that there is any study that was done and it showed that there was any association between coffee drinking and lung cancer, right? So there is coffee, there is drinking, and there is lung cancer. All right. There was a study that was shown that okay, coffee, drinking, and then there's this lung cancer happening. All right. Now, why is this lung cancer happening? Because coffee and drinking does not cause lung cancer, right?
Yes,
Then what is causing lung cancer?
it is.
Smoking. Now, why is it smoking? Because
These
drinking
people are
people,
prone.
people who are drinking are also smoking as well,
Yeah.
right? And that is why lung cancer is happening. So, two things that people are doing, and then the third thing is affecting the outcome, then that will be confounder, which means that that third thing is confounding to the disease. This drinking alone is not causing lung cancer. It
Yes.
was done with smoking, and that is why it caused lung cancer. So they both are confounders in this. You understand? So smoking was a confounding member or the founder member of lung cancer. Okay, along with drinking. So now you got me. What if I would have said that smoking causes lung cancer? Then what this would have been? I told you. What do you mean by
It's effect.
direct?
It's effect modification.
Very good. So now you understand me why I said direct and indirect relationship.
Yes.
Okay. Whenever they say direct from one point to another point, effect modification. Whenever they say 1 point, 2 point, 3 point, 7 point, 8 point, then that's a zigzag, that's always confounding. Now, even if you didn't know the examples, and if I said, okay, smoking causes lung cancer, what is this effect from modification or confounding? You would have immediately picked, oh, Dr. Mine said direct, it's effect modification. You did not need to learn the example or how it can cause effect modification or how it could have been a confounder, right? So, this is how you save time and you study smart, not hard. Okay. And if, for example, there were three things and those two things are causing one outcome, and that is cancer, then that would have been a confounding. Got it? Is it clear to everybody?
Yes.
Yes.
All right. You guys can ask me questions if you feel that, everything is clear.
Yes.
Okay. Then there is
Yes.
last thing that I will tell you guys, and then I'll continue the class from tomorrow because it's already been it it will be 2 hours. Okay. Mean, median, mode. I think this is very easy, right? Mean, median, mode. What do you mean by mean?
It is the
When
sum of all numbers divided by the total number.
yes.
Okay. What will be the mean in this equation?
It will be all these value plus divided by their total number.
So it will be 14 plus 16 plus 15 plus 12 plus 12 divided by 5.
Yes.
Five.
Very good.
Average.
All right. And then you take out the value, and that will be mean, right? What will be median?
It will be taking arranging them in a ascending order, all the values, and then
Hmm.
taking the most middle number. Like 2 will go on that side, 2 will go on that side, and the middle number would be the median.
Right? So if it is like 12, 12, 14, 15, 16, so the median will be in this case what?
14.
40.
40. Very good. What if this would have been an even number? Like what if there would have been also 17 over here in the end? Then how will you would have taken
Then we
out?
take two numbers in the middle and plus them and divide by 2.
Very good. Or you can say 14.5, right? The middle value of both of them.
Yeah,
Okay. How do you take out mode in this now? What is the mode in this?
that's 12. The most frequent number.
Very
12.
good. That's the most frequent number. Okay. So now you know what mean is, what median is, what mode is. Okay. Now, what I want you to know in this as well is a positive skew distribution and a negative skew distribution. Okay. What do you have any idea what skew means? What is a skew? What do you mean by a positive skew and a negative skew? No?
It is basically mean on the graph, like leading towards the right or leading toward the left.
Yeah, very good, very good. Okay. So let me first draw this so that you can guys can get an idea. Okay. Okay. So over this is a positive and this is a negative. Why it's a positive? Because it's going, from here, it's going up and it's going, down. So this is positive. Negative is this upside down thing. All right. So this is a positive skew. This is a negative skew. What I want you to remember, in a positive skew, mean is greater than median, and that is also significantly greater than mode. So the highest value will be
Mean.
mean. So in a positive skew, mean will be the highest and the mode will be the
Low.
lowest. Okay, in negative skew, this will reverse.
Yes.
All right, what will happen now?
Mode will be the highest.
Very
Mean
good.
would be less than medium, which would be less than mode.
Very good. And it will be mode. So what will be the highest in negative skew? The mode will be highest, right? And the lesser will be
Mean.
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 Very good, I think. So, yeah, this is mean. Yeah. Got it? So this is positive skew, negative skew. So whenever you see this type of graph, you will automatically pick mean is the best thing. Okay, mean is the highest and mode is the lowest. Whenever you see this type of graph, then what will you pick? Mode is the highest, mean is the lowest. Okay, understood?
Yes.
All right, guys.
Yes.
So that's
Yes.
the wrap for today. I will give you 5 minutes for a question answer session, and the 2 hours will be up. From tomorrow, we will be doing the questions. I will give you the questions and we will solve them together so that you guys can have an idea on how to solve the questions. There are 2 to 3 more things that are also left in biostatistics portion, and then I will teach you guys that as well. And that is a null hypothesis. That's really important. Type 1, type 2 errors. That's very important. Confidence interval. These 3 to 4 things are also left. And we will see that, if I can cover that along with the questions tomorrow, then we will try to do it. Otherwise, then I will complete the remaining of the chapters first, and then from the day after tomorrow, we will do all the questions together so that it can be in a systematic manner. All right.
Okay.
Okay, guys, it's a wrap. No questions.
Ma'am, I have a question.
Yeah.
So earlier when we were like discussing this thing about case control, which is a retrospective study and which does not take risk factors into consideration. Like
Hmm.
in the there is a line given that, like for example, in the case control study,
Hmm.
patients with COPD had a higher odds of smoking history than those without COPD. I couldn't
Hmm.
understand because also one thing he has like taken reference to this risk factor of smoking and also overall like the example I've not got it now. Could you please?
Hmm. Okay, forget that line. All right. Just remember, diseased compared to without diseased people. That's it. All right. Sometimes it's very confusing for you guys and even for me to understand the dynamics of it. And I'm like, we need to just pass the exams. They do not want us to be epidemiologists, okay? So just remember the basics of it. Do not dive and dissect the line and words, okay? I know it
No,
must be
ma'am, no,
really
I'm so
confusing because
sorry. I'm so sorry to put it that way. The only reason I was asking you because, like you mentioned this, that there will be no mention of any risk factors, but in the
yeah.
exam mention the smoking history is a risk factor. So that is the entire thing. Like because of what I've asked you, I'm so sorry.
Mhm. No, no, it's okay. It's okay completely. You can ask me this, but again, that I'm saying that they will not say that the exposure or the risk factor caused that certain type of disease. They will say that it was they will say any other risk factor per se, but they will never say that that risk factor or exposure went on to form the disease, because if they're saying that, then that means that they are not referring to you as a case control study. They're more likely referring to as a cohort study, because in cohort most of the people are at risk for developing a disease or they're not at risk of developing a disease. In case control, there is no exposure or risk factor that is causing the disease differentiation. right? So we are only, for example, tuberculosis, and we're saying that these are 100 people with TB, 100 people without tuberculosis, and we have to do a study for them. Very, very simple. That means we're talking about case control. If I put immigration as a risk factor, or, as like any sort of, that +1 into that, then that will most likely be a cohort study. Right? If I go and see over the course of 5 years, if they develop TB, all the immigrants who have come to United States, now I will monitor them for over the course of 5 years to see if they get TB, then that will be what? A prospective. But if they've already developed TB and I go back in time, oh my God, okay, how long ago they came to United States so that they developed TB, then that will be a retrospective cohort. Okay.
Got it.
So just for the sake of understanding purposes, try to dissect it. Don't worry, we will solve the questions tomorrow together. So, and you will get a better understanding of how they are asking questions and what they want you to take away from the question.
Okay, ma'am. Thank you so much.
Okay. Don't worry. All right, okay, we are done, guys. I think Dr. Ahmed, are you guys here? Is there a session today with him? Dr. Ahmed, Dr. Hamza, are you guys here? Is he here today? No? Did anybody check the group? What are you saying on the group? Is there a class today?
Nothing mentioned.
Nothing mentioned. Are they taking a class or not? I don't know.
Also, Dr. Maheen, I wanted to ask. So yesterday, our session with Dr. Moyes, like it didn't finish and the call ended. So are we going to complete psych as well, or we just going to do it on our own?
Oh, okay, okay. I think Dr. Ahmed and Dr. Hamza will tell you that, because I have really no idea.
Okay.
I've been really preoccupied. So I think the class has ended now. And you guys, just reach out on the group and ask what's going on, because I have no clue as to if the class is today or not. All right. And I will see you guys tomorrow with remaining of the biostatistics portion. I will try to cover the questions tomorrow as well. If they do not get covered tomorrow, then don't worry. I will compile at least 10 to 15 questions of biostatistics, and I will make you guys do it with me so that you know how to pull out the data from the question. Pulling out the data from the question is the hardest part. All right. Understanding is the easiest part, but pulling out the question when you just see in graphs and numbers, and you're very confused as to what is what. So I will try to make it easier for you guys so that when you actually do the biostatistics blocks, they become very easy for you. Okay. Just don't
Thank
panic
you.
whenever you see a biostatistics question. It's very easy, trust me. But you just have to remember the basics of it. That's it. Even if you're not understanding the concept of it, just remember, oh, Dr. Mind said this. Okay, that this is this. That's it. Just try to get bypass the question. Okay. All right, guys. I will be seeing you guys tomorrow. And yeah, just enjoy the rest of the day. Happy learning. I will see you guys tomorrow. Best of luck. All right, you guys can lead the session, guys. Bye bye.
Thank you, ma'am.
Thank you, Dr. Maheen. Bye.
Thank you.
Hello, Dr. Rauf. Like, are you there still in this meeting?
Are you talking to me?
Yes, brother. Yes, brother.
Yes.
So yes, regarding this case control, if you have like a good understanding regarding that, could you please help me out? I'm finding it difficult to understand what exactly is this case control thing, because ma'am has said not to consider the risk factor, and in the first aid, the smoking as smoking history as a risk factor is given. So could you please help me out regarding that?
Actually, as far as I remember, when I studied the biostats, I did it from the Randy Neal videos, and
Okay.
and I also encourage you to must watch them. His channel is on the YouTube, Randy Neal. Okay.
Sure.
I'll also type it in the chat box. One thing that he says is to best identify that whether it's a cohort or a case control study. He says that in the case control, like case you have A and on control you have O. So A and O. So this means that one group has the disease and the other group does not have the disease. So you
Okay.
also always have to remember like that. So there will be one group that has the disease and one that does not have the disease. It does not. We cannot really, pick it out just on the basis of risk factors. It's difficult to
Oh.
pick out on the basis of that. So we basically look that if there is a diseased group and a non-diseased group. But if it will be a question related to cohort studies, so the like we see in cohort, there are two O's, cohort.
Oh,
That means that both group do not have the disease.
okay.
Both group do not have the disease, and on basis of that we pick that it's a cohort. Then on the basis of risk factor we might move, like are we moving in a prospective direction, like following the groups, like either they develop the disease or not, or either they already have the disease and we are going into the past, taking hospital records or anything, and then looking in a prospective manner, retrospective manner. So that would be a prospective or retrospective cohort. But in the case control, we always have to identify that if there is a one diseased group will be there and a non-diseased group will be there, and then we
Okay.
start putting things on the basis of that.
Got your point.
Yes, but apart from that, I think you should really check out the videos of that Randy Neal, because he also have large videos in which he explains all these concepts. And apart from that, he has 1 or 2 minute shorts in which he solves questions related to case control, cohort, and all other topics related to this.
Got your point, brother. So this is actually the first time I'm like getting a good know about biostats. This is the first time I put in efforts, like listen to lectures. So ma'am has already given some beautiful insights, and also what you have said, what you advised, I'll definitely go through the Randy video. Thank you so much.
Yes, sir. Do check it out, the Randy Neal. Yes.
Thank you so much. Good night.
Yes, no problem.